So I'm going to start with smoking cessation. Dr. Trivedi briefly mentioned it in Dr. Best Marcus's work. Numerous studies have shown to be somewhat efficacious in exercise smoking cessation. One of the first major ones was Dr. Marcus's study in 1997, Commit to Quit 1. And they looked at exercise in addition to CBT. Now, this was done in an ideal controlled situation, in a hospital, in a perfectly controlled situation. It was a 12-week program of vigorous intensity exercise, but they had a kind of run-in period, whereas they didn't start the exercise intervention until the last 3 weeks of the smoking cessation program. So there's a long run-in period of their doing the smoking treatment and then going into the exercise intervention. They did their study 60-85% of the Cravonin formula using the max heart rate from I think it was a cycloergometer test. And interestingly, at this time, they allowed this participants to exercise on pretty much any type of aerobic equipment as long as 50% was done on a stationary bike. So you had a wide range of modalities in this study. A few years later, she followed this up with a Commit to Quit 2 study. Again, a large number of female smokers, and again, exercise or equal contact added on to CBT. However, what was different in this one is they wanted to do this in a less ideal situation. It was done more in a community setting. So in this time, they only did 1 time per week in their study gym. They also reduced the length of the study from 12 weeks to 8 weeks being the minimum amount of time they needed to do the CBT training, and there was no run-in period. I also found interesting looking through the study that this is one of the few studies in these large-scale public health type of studies using exercise that they validated it with or verified the home-based exercise using accelerometers. This one, they also dropped down to moderate intensity exercise. In the ideal setting before, there was vigorous. So they said, well, let's see if moderate, because moderate is maybe something that we can do more on our own at the home-based setting. And the dose, as in Commit to Quit 1, was a time volume per week. So they're aiming for 165 minutes per week approximately over their 5 sessions. And then some of the studies with exercise interventions, depression, most of them done with Dr. Trivedi. This one is in combination with Dr. Dunn. It was done at the Cooper Institute. They randomized individuals. They had 2 questions in this study. One was dose. They looked at a lower dose of 7 kilocalories per week, and kilocalories per week is the number of kilocalories per kilogram or body weight that's going to be completed each week. So they looked at 7 and 17.5. At this time, 17.5, that translates to about 210 minutes of moderate intensity physical activity. The recommendations at this point were most days of the week, so that'd be 30 minutes a day, so times 7, that'd give you your 210. And they also looked to see if frequency had an effect. It didn't matter if it was 3 days a week or 5 times a week. They exercised treadmill or stationary bike, and then did a follow-up continuation phase of 12 weeks. In this one, he was talking about control groups. They tried to exercise placebo control group. This one was they were doing stretching or yoga or just some type of easy movement, but not moderate or vigorous intensity exercise. The results from this, when they looked at frequency, they saw a decrease in HAM-D scores amongst all groups, but there was no significant changes between or differences between the groups. So the frequency they determined didn't really matter. But when they looked at the dose, they saw that while all groups showed improvement from baseline scores, the public health dose of 17.5 kkWs was more efficacious. So that's kind of leading us towards this line of a greater dose. Now I think Tracy is going to present some data next that might disagree with this, but at least at this point, that was the thought. This is followed up with another study that Dr. Trivedi did out of the Cooper Institute again in Dallas, looking at depression again. This one, they wanted to look at whether a low dose of 4 kilocalories or a high dose of 16 would make a difference. And just, again, similar type of setup as you're seeing here, 12 weeks of more controlled, supervised exercise. And then, but still, even during that time period, they're only doing 1 time per week, and the other 2 times are on their own. And then the follow-up, they're doing an additional 12 weeks of home-based exercise on their own. They did, in this one again, they have a choice of treadmills or cycle ergometers, so you're starting to see a more controlled environment for the calculation of caloric expenditure, and they did their max test on cycle ergometers. And I think that looking at some of these studies, that's something to consider, that they're testing people, getting a max heart rate on a cycle ergometer, and then doing a prescription for a treadmill off of that heart rate. And I think there's a little bit of a issue doing that. They did not capture intensity. The participants were allowed to exercise at whatever intensity they felt would suit them the best. And they just monitored this through the heart rate, Finally, the last two studies I'm going to look at are more focused in chronic disease, done with Dr. Tim Church and Stephen Blair. First one was done, again, at Cooper Institute. This is Dr. Church's study in Flame, looking at C-reactive protein. The results were just recently published. They did a 6-week run-in period. Again, they were able to test the participants' desire to be in the study, because once you randomize them, you have to analyze them. So they really tested them, see if they wanted to be in the study, and then they engaged them in 16 weeks of the intervention. This maximal test again was on a cycle ergometer, and then the heart rate intensity was 60-80% of the VO2 max. They, again, 16 KKWs, so we're seeing this similar 16 or 17.5 dose per week over 3 to 5 sessions. Now you're seeing a forced modality between cycle and treadmill. They thought, their thought going into it was that the treadmill would create more injury situations. They said, well, we'll exercise on treadmill because usually it's more acceptable to the participants, but then we'll cycle them off onto a cycle ergometer the next session, and hopefully that'll prevent injury. They did allow a makeup or a carryover of dose, so if I happen to miss one of my laboratory sessions, we would give you a heart rate monitor, and you could do it on your own the weekend and bring the data back to us. So these things I'm going to relate them all to how our study as we go along here. Final study just came out in JAMA. Dr. Church is now out of Pennington down in Baton Rouge. Looking at type 2 diabetics, they had a whole bunch of different groups here, but we're just going to focus on the aerobic condition for now. It's a 9-month intervention. They had these individuals come into the lab, all supervised sessions, nothing at home, all supervised for 9 months. Now they've switched. They've gone max testing on the treadmill, and all the sessions are done on the treadmill. So they're matching the max test with the intervention. And they're doing 12 KKWs. 12 KKWs is approximately 150 minutes per week, which now meets or matches our current guidelines, for physical activity recommendations. They're doing 50 to 80% of maximal oxygen consumption, so this is now in the range of moderate to vigorous, depending on how hard a participant works. So to sum up that, we got a dose. The early studies didn't focus on a dose. They're time-based, 150, 165 minutes. Now this transition to higher doses of KKWs of 16, 17.5, and then recently we're starting to see that come down to about 12 KKWs, which matches our current guidelines. The intensity, almost always moderate, sometimes vigorous, but it's monitored in very different ways. So there's a consistency of that, and as I mentioned, sometimes these max tests are performed on one piece of equipment and the prescriptions on another. Modality, earlier studies, a lot of variability, but now you're seeing movement more and more towards treadmill. When I went out there to train for the study and learn under them, I said, man, treadmill, I'm thinking to myself, runners get injured all the time, and there's no running. And I'll show that. This is speed walking. And once you start to see that vigorous intensity exercise for someone who's physically inactive, their heart rate goes up while they're walking. And they're staying in that vigorous zone with walking. So there's actually very little injury because they're not running. But we always, treadmill with running, but it's actually vigorous walking. And the time and frequency. So the running period, some of these studies, 2 to 6 weeks. I think a running period is ideal, and we don't have one in this study, and I'm going to address that. They all have some supervised or acute phase, most of them 8 to 12 weeks. That one study did out 9 months of controlled sessions. And then we're looking at 3 to 5 times a week, which is pretty normal because most of our interventionists don't want to work on Saturday and Sunday, so we have to cut it off at 5 times a week. So that leads into our study and everything we've learned and trying to incorporate. So just a quick overview, they go through baseline randomization period. This actually takes almost 3 days to do, 3 different visits. We need a fasting blood draw and a medical screening. Then they go to that acute phase, 12 weeks, 3 times a week. Now we are hoping for a 21 to 28 day residential stay. As you mentioned, this is where we're really trying to hook them into the exercise intervention. They're almost on lockdown during this period anyways in the residential stay. And then they're sent, then they're in continuation phase and doing it on their own except for 1 time a week. I want to address medical screening. I think this is kind of unique to our population. You know, they do blood work, medical history, physical exam, and then they do a maximal exercise test. And when I came into this, we were trying to decide, well, according to ACSM, should it be supervised or unsupervised? Let's do the risk stratification. And a lot of our participants probably would qualify as healthy and not need supervision. And I just, at the beginning, I said, I just think that's wrong. I think it's the wrong way to go. I think we should treat drug use and drug dependence as almost a disease condition, and every single case should be, you know, supervised session. So we changed that. All sessions are supervised, which creates another layer of problems because this isn't like an exercise laboratory where we walk down the hallway and do a testing and there's a doctor. We're out in a community treatment center. So now they got to transport that person to a cardiology lab. We got to fit them into a schedule. And this isn't something we schedule a week in advance because this person checks in tomorrow, has 25 days length of stay. We got to get them going right now. So it takes a lot of coordination, cooperation. And I think we're really glad we did it this way because we've had some really neat, or not neat, some interesting things show up. People are excluded from this study if they're on beta blockers. I mean, that's obvious. We're doing, our intensity is based on heart rate, so that would affect that, and physical limitations. But before they're randomized, you can't have any limitations. We did have a case where we almost enrolled someone with a prosthesis, but the person was able to walk. So we're like, okay. We debated this, and if you can walk and get your heart rate in the zone, he actually screened out of the test study for a heart problem and some other issues, but not because of his prosthesis. So it was an interesting situation. So the purpose of our test, obviously, number one, to make sure they're healthy and can participate. We wanted a baseline max value for the exercise prescription. And because we don't have like a metabolic component to this, this is our only way of really seeing level of improvement, how many stages, how much longer they lasted on the treadmill. So we get, one thing we did do, we had to implement this is before we went in to do the testing, we used Tanaka's formula to get a predicted max. Why do you do that? Well, because these guys are smart. They're smart, and they're really manipulative sometimes. And they want their money, and they know they're going to get paid $50 for doing this test. And they think, well, whatever, I'll just throw the test. We had one guy at one site just always fake chest pain. And the minute you're in a max test and you fake chest pain, or say you have chest pain, you're off the treadmill. And we looked at the ECG, and there's nothing wrong with them. And 2 minutes later, he's like, no, I'm fine. Well, we're like, well, you're not in the study. We didn't get a max heart rate. So we had to implement this so that if they don't get within 20 beats of this predicted, they screen fail out. When we told that guy, he's like, oh, can I do it again? Does it again? His heart rate's, you know, above his age predicted. So it's a really manipulative population we have to be really careful of, and these are kind of checks and balances. So, and you can see that, you know, if we don't do that, it could really change our exercise prescription quite a bit. We do it again at week 13. Now they're enrolled in the study. The first time we do the max test, it's screening. They're not in the study yet. They have to pass a test before they're randomized. At this point in week 13, they are in the study. We use it to see if they've improved their fitness. We've had 3 different cases where we've had screen fails, not a screen fail, but a max test fail in week 13. Not week 1, but week 13. Maybe something they did, some drug use in between, damaged their heart some more, but they go in week 13. Now all of a sudden, they can't exercise the rest of the study. Two of the individuals went back that week 13, as abnormalities showed up, doctor wouldn't clear them, so now we lose them from the study. All we get is assessments, but they cannot train anymore. The third case, the doctor actually said, no, you know, you had a little, I think it was ST segment depression. They put in some stents, gave him 4 weeks off, and he's actually back in the study now, and they cleared him exercise again. It was just really kind of interesting stuff. But I'm glad we had this testing, and we could do that with them. So a person shows up today, they're ready to exercise. We have our exercise facilitators. We have one right here, Noberto, you want to just wave? He's in New York, he's at our New York site. Person shows up, gonna exercise with Noberto. Well, in a regular population, that's okay. But in this group, this guy might have been on a binge last night. Now he comes in, and Noberto's got to make a decision. Wow, he really kind of got messed up last night. Should I be putting him on a treadmill at vigorous intensity today? So we don't really have a lot of fancy equipment at our site, so we had to come up with something. So we have this exercise readiness form, and they have to, if their heart rate or blood pressure is over a certain level acutely, then they're going to screen, they can't exercise. They're not cleared to exercise that day, and they have to go home. And we've actually used this in several cases. And they can always use their judgment. We have one lady at a site here that comes in drunk almost every time, and if she's really, we can't exercise her. And they don't get their payment for that session. So it's something we do every time, and just for their safety. So the doses we've been talking about, KKWs, we ramp it up. We go 6, 9, and then 12 for the rest of the study. We weigh them week to week. So some weeks, they might change a little bit. Their prescription might change 20 to 50 calories a week, not a huge deal. So that's our dose. And dose is most important in this study. Everything's doing dose. So if you have a really heavy individual, they're going to be doing a really high dose, and a lighter individual will be doing a much lower dose.